Thanks a million. I am so happy to be here. I think it's a remarkable opportunity to talk with those that are in the thick of it, is how I would describe it. I think it's particularly exciting for me because we are at a phenomenal time as a medical oncologist with new treatments, with new diagnostic tools, with every opportunity to see real change and real improvements for our patients. Just as a broad outline, I'm going to give a slight overview on the current statistics. I'm then going to talk about the breast cancer subtypes and then look actually at the treatment approaches, giving us an overview at what's available now, looking at, or at least explaining the expanded access programs, or also known as compassionate access programs, clinical trials, and breast cancer research. While breast cancer research here in the outline is at the bottom of the list, it is breast cancer research or cancer research in general that really informs all aspects of this presentation. I think it's really quite stark when we look at the statistics to say that 1 in 9 women will develop breast cancer. Even more concerning when we think about the fact that 1 in 3 will develop cancer in their lifetime. We can't forget that 1% of breast cancers do affect men. In total, there are 3,700 new cases of breast cancer in Ireland per year. Almost a quarter of those are in those less than 50. When we think about, if we look at this graph actually spans over 30 years. And in the 30 years, we've had a 30% increase in the incidence of cancer, with now over 130 per 100,000 new cases per year. What's much more reassuring is when we now look at the mortality. And deaths from breast cancer is taking a slow but steady decline over the last 30 years. This is I think, a much easier graph to look at. At the very bottom, we have the 5-year survival for breast cancer in the early 90s, which sat at 72%. But now, in 2018, we have breast cancer survival, 5-year survival rates almost at 90%. All of you here are aware of, but just to point out that stage 4, also known as advanced breast cancer, also known as metastatic breast cancer, it involves disease that has extended beyond the breast or the locoregional lymph nodes. But it can mean an awful lot of different things for different patients. On the left-hand side of this picture, you will see, sort of for some, stage 4 breast cancer may involve just a solitary site of disease. For others, it may be what we call oligometastatic, which means that they have a small number of different sites within their body. And for others, it means more disseminated, more involved areas. And our approach does vary depending on the actual presentation. What is quite scary is that 5 to 8% of breast cancer is diagnosed as metastatic. This consists of 2 broad groups. The first, which is the more common, is that patients in whom there was a history of breast cancer and their disease has come back in an advanced fashion. But for others, it's that they have what we call a de novo presentation, which means that they presented with advanced cancer. When we think about breast cancer treatments, we need to understand the different breast types. And when we're talking about breast cancer, we're looking at a number of different markers on the cell that differentiate the cancer into different types. In particular, we're looking at 3 markers: the estrogen receptor, the progesterone receptor, and the HER2 receptor. We say it's due to the presence or absence of one of these markers, but that's not actually true. It's that these markers, the ER, the PR, or the HER2, are overexpressed. So these are normal proteins that may have a beneficial effect within our cells when they're present in normal quantities, but when they're present in an overexpressed or amplified manner, that's when they cause a problem. But understanding the presence or absence of these, the overexpression of these, helps to differentiate breast cancer into different types. On the far left, we have the hormone receptor positive, HER2 negative, which represents 73% of all breast cancers, and this is also known as luminal A. On the far right, we have the triple negative, which represents 13%. And then we have HER2 positive breast cancers may either be associated with hormone receptor positivity or hormone receptor negativity in 5 and 10% respectively. When we think about breast cancer treatment, or when we think about cancer treatment in general, it is always a balancing act. It's a balancing act looking at the potential side effects of treatment, but it's also balancing what are the potential benefits. When we think about adjuvant treatment, so patients in whom they've had surgery to remove their cancer and they're looking at additional treatments that are helping to reduce risk of recurrence. It's not an easy situation when they're talking about chemotherapy and taking it on board at any time of anybody's cancer journey. But those patients sometimes have the ability to put their lives on hold, to be able to say, I'm going to give a certain amount of months to this treatment, and then I'm going to be able to recover from this. That's not the case when we're talking about advanced breast cancer. We can't put life on hold because life has to go on. And so it's even more challenging in this situation when we're thinking about treatments, trying to balance the physical toxicity, the financial toxicity, time toxicities, and there's so many potential toxicities of treatment that we have to have a holistic approach, and we have to sit down and talk about what are our goals of treatment. What is acceptable to the patient, to their family, and knowing that what we're trying to do is control the cancer and to maintain a quality of life. This looks like a very complicated slide, but this slide is outlining the various subtypes of breast cancer that are available. It's then going into the various treatment options that we would use. And this is a guideline, and this guideline is actually from the European Society of Medical Oncologists, but we have similar guidelines in Ireland. We have the same guidelines in America. We all use the same blueprint. And this blueprint is to inform us or direct us in the right direction, but when we're talking to a patient, it's all about individualization, sitting down and talking to them about what their goals of treatment are, what's acceptable to them, and then trying to move forward. Understanding that this is a journey. So if we talk about the commonest breast cancer subtype, luminal A or HR, hormone receptor positive, HER2 negative. Broadly, this can be divided up into two groups. Those that are treated with hormonal manipulation, hormonal therapy, and this varies depending on whether the patient is premenopausal or postmenopausal, and we're going to go into these subtypes in a little bit more detail. And then we talk about, and what's listed here is chemotherapy. This really should be systemic anti-cancer therapy. It's a broader group of drugs that are used to beaten down the cancer. So many patients, when I first sit down and I talk to them about treatment options, they come in and expect chemotherapy. And they expect that, that their advanced cancer is going to be hit with the toughest of treatments. And they're a little surprised at the start when we start talking about potentially a tablet, maybe an injection of treatment. But hormone manipulation in the hormone receptor positive breast cancer can have phenomenal successes. Endocrine manipulation can either reduce the amount of estrogen within the system, or it can block the effect of estrogen within the system. And I'm going to show you a cartoon on exactly how this works. But endocrine is the cornerstone of treatment in this situation because it's less toxic. It has the potential to have durable results. And I say to patients, we're going to get to chemotherapy at some stage. But if we can delay chemotherapy as long as possible, if we can get the best balance with regard to quality of life, tolerance of treatment, and looking for longevity, that's essentially what we have. Now, sometimes treatments don't work. And unfortunately, before we start, we don't have the ability to look into the future. And so it is, in truth, trial and error. But the majority of patients with hormone-sensitive breast cancer will get some result from hormone manipulation. If one thinks about how do these drugs work, normally estrogen, which is circulating in our system, has to attach to receptors, and when it attaches to the estrogen receptor, it then has an impact on cell growth. And in the hormone receptor positive patient with the overexpression of the estrogen and progesterone receptors, this is revved up. Tamoxifen is a drug that blocks the receptor. If the receptor is blocked, then it can't work. And tamoxifen is a drug that has been around since the 1960s. And it has been a very effective, one of the most successful breast cancer drugs that we have. But we have better drugs. Aromatase inhibitors in the postmenopausal woman blocks the production of estrogen in the system. And if it blocks the production of estrogen, then the estrogen isn't there to have its effect. But all treatments will stop working at some stage. And they stop working because of what we call endocrine resistance. And this is where breast cancer research has really transformed our way of thinking. We now have a much better understanding of how resistance happens. There are 3 well-defined pathways, looking at the ESR mutations, cell cycle, checkpoint regulations, or PI3K mTOR signaling. So these are pathways within the cell that can be manipulated by that cancer cell who wants to live. And it's fighting all of the time, adapting and changing. And so we, as the clinicians, need to be watching our patients and moving forward and adapting when we see the cancer cell change. One of the great advances in the last 10 years has been the development of drugs that can attack or that can impact on CDK, cyclin-dependent kinase 4 and 6. This is a very significant way at which endocrine resistance happens. Abemaciclib, palbociclib, and ribociclib are 3 drugs that are now available globally that have been shown to have a benefit in reducing the risk of endocrine resistance. What they do is they delay the onset of resistance, knowing that it'll happen at some stage. This is a cartoon which outlines 5 clinical trials. The first 3 were in the use of ribociclib, the last 2 in the use of palbociclib. And what they showed consistently is that with the addition of CDK4/6, these tablet forms of treatments, that we were able to get longer from our endocrine treatment. There was a doubling of time for patients to have disease control. So it went from having disease control for 13 months to 24, and it was consistent amongst all of the drugs. This is a picture of a patient who in 2017 had liver metastases. I'm not sure if you can appreciate this little black dot here is one of the liver metastases. And this patient went on, as you'll see, she's young, she was premenopausal. So she went on a medicine which was an injection to stop her ovaries working, blocking the production of estrogen. She went on an aromatase inhibitor, which stopped the production of estrogen in our fat cells. And she went on a CDK4/6 inhibitor. And now, 5 years later, she has never attended a day ward. She initially attended quite frequently every 2 weeks for blood tests. Then it was once a month, and then it was every 3 months. Now she's attending every 3 months. Initially, she used to have imaging every 3 months. Now she has imaging every 6 months, with evidence of her disease having disappeared. So the landscape of hormone receptor positive metastatic breast cancer has really changed from the 1970s, when tamoxifen was the only drug that we really had, which is still successful, but to now, when we have better endocrine blockers, manipulations of hormone resistance, it really is phenomenal what we have and what is continuing to improve. I talked about cyclin-dependent kinase CDK4/6 inhibitors, but there are other pathways of resistance. And when somebody progresses on an agent, we try and figure out what's the reason for it. Is there another driver? Is there another reason why they become resistant to their treatment? And PI3K is a signaling pathway, a cell in the cell cycle which drives cell growth. But we now have drugs that can target that and that can block that effect within the cancer cell. Patients who have a BRCA mutation, we have drugs that again can interfere with that and try and reverse the effect that BRCA mutations can have within the cell. But we invariably will come to chemotherapy with patients. And chemotherapy shouldn't be associated with all negative thoughts, because chemotherapy can be hugely successful. It can be very well tolerated. It comes in many different flavors. There are oral chemotherapies which allow people to function outside of the hospital. Metronomic chemotherapy is a way in giving chemotherapy in a low-dose continuous fashion, which is remarkably well tolerated. And then we have the more traditionally known intravenous chemotherapies, which can be given in many different facets, whether it is once a week, once every 3 weeks, once every 4 weeks, once every 6 weeks. And the choice of chemotherapy very much depends on the person in front of you. What's acceptable with regard to side effects? What's acceptable with regard to visits to hospital? Time toxicity is one of these things that we have to be very much aware of, because our patients are trying to live the best life that they can, and we have to be able to try and support them in that manner. Novel agents, and this is why my job is very exciting at the moment. New agents are being developed all of the time. 2 drugs that are approved in America as well as Europe are trastuzumab deruxtecan and sacituzumab govitecan, and we're going to talk about both in a little while. They're not yet available in Ireland, and we are actually lagging a little bit behind with regard to drug approval. And that has changed in the last 20 years. We're slower now at approving drugs than we used to be. But, you know, we are getting there. This is an older lady who had advanced breast cancer. And again, it was liver disease that she had. And here we have, there's lots of black dots in this area. But in her 5-year journey, she first went on a hormonal manipulation, and she got 3 years of disease control with a tablet form of treatment. She then went on to an injectable hormone manipulator called Faslodex or fulvestrant, but that didn't last for long. She then went on metronomic chemotherapy, and so an oral treatment that was given for 18 months. And in that time, in 5 years, the 79-year-old lady only went into hospital twice in 2020 and once in 2022. And so, again, living the best life that she could. HER2-positive breast cancer. And if you remember, HER2-positive, it can be either hormone receptor positive and HER2-positive, which is known as triple positive, or it can be HER2-positive and hormone receptor negative, and that represents about 15% of the cancers. A phenomenal example of cancer research was essentially the meeting of Dennis Slayman, an American oncologist, in 1987. He met Dr. Ulrich, who was a scientist, and this scientist was presenting at a medical conference about HER2. They identified this protein that was present on the cell, and they had a sense that this, it was impacting on cancer survivals. Over the next 12 years, they were able to show that HER2 overexpression was associated with worse outcomes, with survivals of only 3% compared to those where it wasn't overexpressed. But what they were able to do was develop a drug, an antibody, a monoclonal antibody. Everybody hears of antibiotics, which are devised to fight bacteria. Antibodies are devised to target a spot within the cancer cell, a driving force within that cancer cell. And so trastuzumab is one anti-HER2 antibody. It connects to the HER2 and downregulates it. And by downregulating it, it stops it working. It makes chemotherapy work better. It stimulates the immune system, and it stops the cancer from growing and even, in fact, can cause regression. Trastuzumab was the first anti-HER2 drug, and I remember being at the conference in 2001 when it was presented at the American meeting, and it got a standing ovation because this was a drug that we knew was going to change the lives for 15% of patients with breast cancer, but it was changing lives. If we look at the pathway or timeline over, we now have more than just trastuzumab. We have lapatinib, which is an oral anti-HER2 antibody or small molecule. We have pertuzumab, we have TDM1, and we're going to talk a little bit about antibody drug conjugates next. But this was a hugely changing point for HER2-positive breast cancer. And what was phenomenal for me was that we came back from that meeting in 2001, and within 6 months, we were giving the drug. So in Ireland, we were able to have greater access to drugs at that time. Just like endocrine resistance happens to every treatment. The cancer works really hard at adapting, at changing, at outsmarting the treatments we have. And resistance can happen to trastuzumab as well. But we're getting better, and our scientists are phenomenal at identifying the ways that these are happening. And then we're getting better at actually producing drugs to tackle it. TDM1 is one antibody drug conjugate that has been designed to, and it was first licensed for use in patients whose disease were progressing on trastuzumab or Herceptin. And so this is a really exciting arena that we're now developing other anti-HER2 drugs that can overcome trastuzumab resistance. So TDM1, what's nice about this, we have the purple antibody. And as I said before, the antibody attaches to the target and causes it to downregulate. But an antibody drug conjugate is a type of treatment that has an antibody and a linker, and it's connected to chemotherapy. So the antibody is just the taxi. It's bringing the chemotherapy drug to the cancer cell. It's then internalized, the chemotherapy is released, and so we're getting better drug absorption at the area where we want it, so we're getting more effective treatment and we're getting less side effects. This year, there was another standing ovation, and it was for this drug, Enhertu. And Enhertu is a different antibody drug conjugate, trastuzumab deruxtecan. They're making it more complicated, but the good thing is that we're shortening everything to try and make it possible. So this is TXDD. So trastuzumab deruxtecan is an antibody drug conjugate. And why this got a standing ovation now, almost 20 years after trastuzumab got it, is that this appears to be more successful in a greater proportion of patients. This appears to be successful in patients that are what we call HER2 low, which traditionally would not have got a HER2 blocking therapy. Triple negative. If you remember, that represented 13% of all breast cancer presentations. And this is where we don't have overexpression of the ER, the PR, or the HER2. Triple negative, I must say, people talk about and come into me one hearing and they go, do I have the aggressive one? And I hate that word aggressive, because automatically people are on the edge of their seat, and it really is, whether it's the edge of the seat or the precipice of the cliff. People, it just takes something small that is said to push them over the edge. Triple negative breast cancer has been associated with some poorer outcomes, but there are many variations of triple negative breast cancer. And I have patients with triple negative breast cancer that have lived years. And it again is back to the same old preface of individualizing the treatment to the person who's in front of you. What has changed our approach to triple negative breast cancers, and this is really in, again, the last 5 to 7 years, has been immune checkpoint inhibitors. Immunotherapy is the broad name to these. But one of the drugs listed up here, ipilimumab, was a drug that I was doing some initial research back 20 years ago. But now it and better drugs, pembrolizumab, nivolumab, are being investigated in the setting of not only advanced triple-negative breast cancer, but also in early triple-negative breast cancer, and more globally in breast cancer in general. Immune checkpoint inhibitors, we believe that cancer occurs because, or at least very simplistically, that our immune system wasn't effective at mopping up that nasty cancer cell. It didn't get rid of it. And by taking the brakes off the immune system, we're revving up our own system to try and attack that cancer cell, to try and get rid of that cancer cell. Impassion 130 was one of the first clinical trials to show a benefit of immunotherapy in triple-negative breast cancer. And this was in patients who had advanced breast cancer. And looking at this graph, this is what we call a survival graph. And it's comparing two things. We have the top line is the blue line, which is immunotherapy plus chemo. And the red line is the bottom, the red or bottom line is chemotherapy alone. If you see a survival graph like this, and you can put your finger, when you're staring at it, in between the two lines, it means that there's a difference between A and B. If they're overlapping, there is no difference between the two studies. And here we can clearly see a difference between immunotherapy and chemotherapy itself. Median overall survival, and just to spend just a tick talking about that. So the survival difference in this study was 7.5 months. That doesn't sound like an awful lot, but when we talk a median is that middle value. So if you have 100 people, well, you know, what happened to that 50 person, which is giving us a kind of average, but not. So what's more important is the range. And so in this study with advanced triple-negative breast cancer, the range of survival in the patients that received immunotherapy and chemotherapy, it ranged from 19 months to 30 months. So there were patients who were having a prolonged cancer control period on this agent. Similarly, pembrolizumab has been shown to have the same beneficial effect. The challenge is that immunotherapy is a very expensive form of treatment, and it's only Ireland again lagged behind the world with regard to its approval in this setting of triple-negative breast cancer. And in Ireland, it's only been approved in the last 3 months. I mentioned very briefly BRCA, and BRCA is a gene which is responsible for DNA repair. And there are some patients in whom they have an inherited breast cancer, and so that they have either a BRCA1 or a BRCA2 mutation. And this makes them more at risk of developing breast cancer. But again, we have clinical trials that have shown, and these are advanced clinical trials demonstrating an improved survival with the use of drugs that can inhibit PARP. And that is the means by which we try and reverse the effect of the BRCA. gene mutations. Sacituzumab govitecan, a drug not yet available as standard of care, is available in the US and Europe. It's an antibody drug conjugate again. Remember that taxi that brings it to the cancer cell gets taken into the cancer cell and kills it. But this time the target is TROP2. And this is of benefit in all comers. And this, this I think will likely improve things significantly again for a cohort of patients. I've talked about how difficult it sometimes is to get drugs approved and that Ireland is lagging a little bit behind. But we do sometimes get access to drugs through extended access programs, also known as compassionate access programs. And just to say a little bit about them. So it allows us access to novel or new drugs. Some people call experimental or investigational, but they haven't yet been approved in a jurisdiction. Usually they're based on, when we look for a compassionate access program here in Ireland, it's because it's been approved elsewhere, and we're approaching the drug companies saying, we need access, you give us access, then we can fight, sort of the National Cancer Control Programme to get this approved. And so it's for patients that don't have access to a clinical trial, they don't have any approved treatments, and that they've perhaps gone through most other lines of treatment. In Ireland, there are 37 drugs available on expanded access programs. And it involves, it's a little work from the perspective of your team to get to them. But we're very motivated as your advocates to be pushing all of the time for access to these drugs. When we think about advanced breast cancer, we have access, or at least to breast cancer, we have access to 3 EAPs. Abemaciclib, which is a new cyclin-dependent kinase 4/6 inhibitor. We have Alpelisib, which is a PI3K inhibitor. And then trastuzumab deruxtecan, Enhertu, which is the drug that got the standing ovation this year. We currently have an EAP open as well. Clinical trials. Clinical trials are the cornerstone of the future, of future developments of drugs. And clinical trials have been around for a long time. And even though Ireland is a very small country, it has stood at many podiums as part of international collaborative groups with our patients contributing to advances in cancer research. There are a variety of different types of clinical trials, and when we think about phase 0 or preclinical, it's work within the lab. Phase 1 is trying to figure out, is a drug toxic or not? Phase 2 gives us more information with regard to drug toxicity. Phase 3 is where we're comparing it to a standard of care. In Ireland, we've had 15,000 patients over the last 30 years involved in clinical trials. Why consider it? We consider it because the hope is that the new study treatment may be better than the standard. For some people, it's the ability to participate in cutting-edge medicine. And there are some people, who truly have an altruistic benefit. I know that this may not work, and particularly when we talk about phase 1 and phase 2 studies, the chances of that drug being effective in an early phase is very small. But patients will come and will sign up to those studies because they want to help other people. And the purpose of medical research is to push boundaries so we can improve care. But people worry about clinical trials. I hate the word experiment. People feel that they are experimented on. There's an unknown, and depending on what phase of study the trial is, there may be unheard of side effects in the phase 1 studies. Sometimes being part of a clinical trial requires extra biopsies, extra blood tests, extra scans. And there's a concern that the decision is made on the flip of a coin when we talk about randomized phase studies. But I think what's important to realise is that when any clinical trial is actually offered to a patient, it has previously gone through medical ethics committees and usually gone through much design, much adaptation to get to that end product that's being offered to you. This is a small study, and studies are a variety of studies. Sometimes they're reviews. This was a small study that Dr. Conleth Murphy did in the Bonds, looking at complementary and alternative medicine. And I'm a big advocate of using CAM in concert with traditional approaches. But only a third of people discussed their complementary and alternative medicines with their team. And that can lead to undue problems, not understanding the interactions between them. This is just an example of a study that is available in the country currently, which is looking at alpelisib and fulvestrant versus a placebo in patients with advanced breast cancer. And again, another example of a study which is looking at other newer HER2 defining treatments. As I said at the start, while research is the cornerstone of development, and it really drives and pushes us to try and improve our situation for our patients, Irish clinicians, Irish academics are very productive. And this is a list of, and only a fraction of the list of publications, and these are international publications from Irish clinicians and scientists with regard to breast cancer research. So I think it's important that if we take an overview of the treatments that are available and where do we go from here. The most important thing is that we're trying to marry and individualise treatments for our patients. While, of course, living longer is the key, maintaining quality of life is equally important. We're trying to look at situations where we don't get cumulative toxicity, where we keep the patient being able to live the best life that they can and avoid hospitalisation. And some agents that have been phenomenal in allowing that are this combo of pertuzumab and trastuzumab, a combination of two HER2 blocking agents, the oral CDK4/6s, and oral chemotherapies. I'm a glass half full kind of person, and sometimes these things can be trite, but I love them. And when it rains, look for rainbows, and when it's dark, look for the stars. But it's easy for me to say that because I'm not sitting at the other side of my desk. And I think what I always point out to patients is that we have a plan, and we have a plan, but the problem is that sometimes cancer doesn't allow the plan to go in the right direction. And we have to readjust that plan at regular intervals. And I think it's important that you have the relationship with your physician, your team, that is going to allow you to achieve your goals. And it really is one day at a time, one step at a time. I'm not sure now did I go over time, but apologies.